Hello, my name's Chris Griffiths. I'm Professor of Dermatology at the University of Manchester and also at King's College, London. I'm also a practicing clinician. And my colleague, who I'll hand over to now just to introduce herself.
Hello, thank you, Chris. My name is Su Lwin. I'm a dermatology registrar at St John's Institute of Dermatology at Guy's and St Thomas's in London, and a visiting lecturer at King's College London in the UK.
Thank you, Sue. So we are delighted to talk to you today about some experimental work that we have performed on the use of mesenchymal stromal cells for the treatment of severe psoriasis. And I'll give you a bit of background as to why we've taken this route to management of psoriasis. Those of you who are watching and those of you who have psoriasis will know that there's been huge progress in the last 20 years of understanding the immune processes involved in driving psoriasis and then developing therapies called biologics, which are targeted to key components of the immune system. I think it's fair to say that these biologics have transformed the lives of patients with very severe psoriasis. And so much so that now we require far fewer hospital beds for management of psoriasis than we did even 5-10 years ago. However, despite all that tremendous progress and people really having a transformation in their lives, we've reached the stage, unfortunately, where some patients, we don't know the reasons why, have tried and failed all classes of available biologic therapies. So that may have been they've tried and failed eventually 7 different biologic drugs. Now, what do we do in that situation? Well, this is a situation that I think is becoming increasingly important, not just in the UK, but across the world. And any physician who manages these patients will know there's an increasing number of them who we have run out of traditional options to manage them. But as responsible clinician scientists, we're always looking for new therapeutic avenues. And one of these is called advanced therapeutics. And I'm going to hand over to Sue to tell you a little bit more about the opportunities inherent in that new form of treatment.
So advanced therapeutics, now what is advanced therapeutics? Let me start there. So that involves what's called stem cell and gene therapy, in short, and we're going to focus on just the stem cell therapy, which is relevant to what we're trying to do in psoriasis. So what are stem cells, first of all? So stem cells, you may have heard about stem cells having the potential to turn into any other form of cells that make up our body. So there are so many different types of stem cells, so they can be sourced from different tissue types from adults and not the embryos as once upon a time was known. So that's back in the days, and this is no longer permitted, and we don't use any embryonic stem cells. But thanks to science, we have actually discovered so many different sources of stem cells, such as the mesenchymal stem cells or stroma cells, and there are other stem cells such as keratinocyte stem cells and so on. So these stem cells have different properties, such as regenerating damaged tissue or having anti-inflammatory effects. So in particular, mesenchymal stem cells or mesenchymal stromal cells, or MSCs in short, are particularly attractive because of their anti-inflammatory or also known as immunomodulatory properties. So essentially, these are what's called, they have the potential to turn into different other cell forms, but importantly, the anti-inflammatory effects have been noted by various scientists and researchers, and that's actually tested in other inflammatory diseases such as rheumatoid arthritis, as well as inflammatory bowel disease. So that's actually been well used in clinical trial context, and their safety has been proven for many, many years. And currently there are more than 1,600 clinical trials ongoing using these MSCs. Now, a little bit about how they work really, because that's the key to understanding why we are looking into these MSCs. So first of all, I mean, I have had the privilege of using these mesenchymal stem cells firsthand in a different skin disease called epidermolysis bullosa, which is a rare genetic skin disease where you have blisters from birth till death, and also really significant inflammation of the chronic wounds. So in these patients, we've learned the potential, the regenerative potential of MSCs, as well as the anti-inflammatory effect. So how do they work? It's actually not the live MSCs. These are not the live cells that mediate the effect. But what happens is that when you inject these MSCs into the vein, it enters the blood circulation, where the person's immune cells then kill these MSCs. And so these MSCs, the dead MSCs, so to speak, then release various factors which then mediate that potent anti-inflammatory effect. So that's how the MSCs work. So not the live MSCs, but the dead MSCs. And also the person's ability to kill the MSCs effectively help predict how the person responds to the MSCs as well. So that's being well worked through with our collaborator, Professor Francesco Dazzi at King's College London as well. So this is just to give you a bit of background on MSCs and how they work and what we've had in terms of first-hand experience in a different skin disease. So I'm just going to hand it back to Professor Chris Griffiths on the 2 patients with severe psoriasis that we treated using the MSCs.
Well, thank you, Sue. And that's so that's the background. And as I mentioned when we introduced ourselves, I have professorial appointments in Manchester, which is where I started, and now more recently at King's College London, working specifically at King's College Hospital in South London. And one of the reasons that I made that move was to take forward this pioneering opportunity to use cell therapy to manage patients with severe skin disease, and that's particularly psoriasis. And that's because of the expertise that resides at King's College Hospital with Professor Francesco Dazzi's department. And he has done a lot of the early work on cell therapy for other indications. So these first 2 patients, what we identified are very similar, interestingly. This is done on a compassionate basis. So this is not part of a clinical trial. These are 2 patients with severe disease, and I'll tell you a bit more about them in a moment, who have exhausted all current therapeutic options. They've had an initial response to biologic therapies, but then that response has declined over time, and they've now failed all of them. We have identified 2 patients, both women. First one is aged 46. She has had psoriasis for most of her life, very severe disease. Those of you who know a bit about psoriasis will know that a PASI of 37 is really very extensive disease. She also had some other associated comorbidities, including psoriatic arthritis, which occurs in about 30% of people with severe psoriasis. And she was very significantly psychologically disabled by the disease. And so, as you all know, there's a psychosocial aspect to living with psoriasis. She was also on a biologic called etanercept, which she had previously been on and then restarted about 6 months before we treated her with MSCs. But this was having no benefit as far as we could ascertain. The second patient, a little bit younger, 45 years of age, also had psoriasis for most of her life, but had no comorbidities in the sense she didn't have psoriatic arthritis. She again had tried and failed all available biologic therapies, and the current one that she was on was an anti-23p19 inhibitor. It's a very sophisticated form of biologic therapy targeting interleukin-23. And this is delivered over 8 weekly cycles, but she was not maintaining any form of response, beyond a couple of weeks. So she also was failing. The extent of her disease was not so severe, but it was still severe enough to have a very limited quality of life. Sue mentioned about this assay, this killing assay that Professor Datsey has developed. Both of these patients were tested for the assay to see the extent that the immune system could kill the MSCs. The first patient was just above the normal range, so just was her cells were able to kill the MSCs, but not at a very high level. Whilst the second patient had a much higher level of what's called cytotoxic killing, which means that more likely she would respond well to the MSCs. But these were the first patients that we had treated, so we had no idea whether this assay would be relevant. So after going through the necessary consent procedures, and which is of course very involved with these two patients, even though we know from previous studies that these are in a sense safe, we can't be complacent about that. So both patients were fully informed of the risks and possible benefits of this approach. They knew that it was experimental, but were very happy to be part of these a very initial study. And I'll now hand back to Sue to tell you some of the exciting data that we have from both the clinical side and also from we looked at the immunology of the response, and that was work in collaboration with Dr. Paolo Di Miglio also at King's College London. So over to you, Sue.
Thank you, Chris. So really quite fascinating and exciting findings actually in the first 2 patients ever that we've treated with severe multiple biologic resistance psoriasis, as Professor Griffiths mentioned. So in patient 1, so we used the MSCs alongside the etanercept biosimilar Benapali that she was on. So MSCs was used as an adjuvant therapy rather than a single therapy. Now, in this patient, she was borderline positive for that cytotoxic killing assay that Professor Griffiths mentioned. And she actually, as expected, she didn't respond so highly, but a moderate response. But actually, the moderate response was sustained up to 6 months. So really quite significant for her. So PASI initially was 37.6, as we heard earlier, and that actually came down by 40%. So 40% improvement in her PASI. And that actually meant that, for the patient, she was able to go out and do certain daily routines again for the first time in many, many years. And that was a very clinically meaningful impact for her. Now, despite the moderate response, the response was sustained up to 6 months when she began to relapse. So we've learned actually from this patient that, the borderline positive assay did demonstrate a moderate response, but actually in a sustained manner. She also had a 50% improvement in itch, and also DLQI followed the pattern of her PASI improvement as well. She had the psoriatic arthritis, and her tender joint count, so the assessment of the number of joints that was tender, also improved by about 50% as well. So in patient number 2, quite different from patient number 1. So she had a very high response to treatment, as we predicted based on the strong positive assay for the cytotoxic killing. So she had a high response to MSCs, but actually the response was short-lived. So her PASI improved by about 40% within the first week of infusion, with a further improvement up to 87% by week 4. So optimally, she had an improvement in PASI by 87%. But that response quickly relapsed by week 9, as opposed to 6 months in patient 1. So in this patient, it is important to note that she was failing the treatment with guselkumab, and we actually stopped her guselkumab at baseline. So in this patient, on the contrary to patient 1, we used the MSCs as a single therapy or monotherapy. So again, we are talking about a multiple, biologic resistant patient who never ever had any improvement in her psoriasis to this level of extent at all. And she was also beginning to fail guselkumab as well by the time. So this was, again, a clinically meaningful response for her. Now, we looked at the immune cells of these 2 patients. So there are so many different signals that we looked at, but just to simplify, there are 3 key findings that we saw. One was that the immune cell responses did mirror the clinical responses, roughly. The second was that the immune cells, which are known to have inflammatory signatures, became non-inflammatory after the infusion with MSCs in both patients. So that was really quite a remarkable finding, as we expected. So in a way, one could extrapolate that MSCs have the ability to turn some of the inflammatory immune cells into non-inflammatory signatures. Now, the third finding was that the 2 patients had very different immune profiles. So there are different signals or signatures that we can define the patient's immune profiles. For instance, one is called IL-17, another one is called interferon gamma. So these are the labels of the signals. In patient 1, it was mainly IL-17, which is a characteristic profile of psoriasis. And in patient 2, it's actually interferon gamma. So they've got quite different profile as well. So that tells us that it may be the different immune profile of patients that may help determine partly how they respond to the MSCs. And just to summarize, overall, the immune profile do reflect quite closely with their therapeutic, their treatment response. And we did see moderate changes in patient 1 and quite dramatic changes in patient 2. So over to you, Chris, just to conclude the findings.
Well, thank you, Sue. So we are really very excited about these findings. And in fact, just a week ago, Sue made a presentation about these early data at the first International Societies for Investigative Dermatology meeting in Tokyo, where this was very well received, with lots of questions from people as to how we're going to take it forward. So the next steps for us, we have a third patient lined up for MSC therapy, probably in a couple of months' time, very similar to the previous patients that you've heard Sue describe. But I think with the data we have so far and the immunological data as well, our plans are that we want to move into a more formal study to really understand the dosing regimen, which were the ideal patients to treat with this particular form of advanced therapeutics, and also to understand more the immune mechanisms that drive the response. And maybe these patients that we'll treat in the study, in the trial, will be less severe than the 2 ladies we've told you about today, but still have very severe psoriasis and will still have failed maybe 1 or probably 2 biologic therapies. But I think as we start to make progress with advanced therapeutics and cell therapy in particular, I think we are on the very margins now of an exciting new therapeutic way for the management of not just psoriasis, but other inflammatory skin diseases. So watch this space. I think things are going to start moving really quite quickly. Thank you for listening, and I hope you found this useful.